Thank you, everyone. Thanks, Tino, for the intro. My name is Isaac. I'm one of the directors at ANTA and the Remedial Therapies Chair. Thank you for having me today. I was just going to say it's such a nice change of pace coming from Melbourne to Perth because the weather's so good, but just after the break we've got a leak coming through. I don't think it's raining outside, so I was just about to say it makes me feel at home, but no, thank you for having us. It's always really nice to come over here. Great people, great atmosphere, great climate, so I really enjoy coming over here every year and presenting to you. So thanks for having me. So today my presentation is going to be surrounded by a typically really challenging condition that practitioners face, which is osteitis pubis, typically found within an athletic population. I'm going to embed 3 lessons though for chronic or challenging presentations. So there'll be something in here for everyone. But just to get a show of hands, who's a manual therapist in the room? Manual therapist, nice hand. Okay, so quite a few are great. What about ingestives, natural therapy, nutrition? Yep, great, quite a few of you as well. TCM, acupuncture, Chinese medicine, a couple, great. Have I missed anyone? Arm up nice and high if I have. No, great. So we all face chronic conditions. Quite often a lot of them are painful. So that's what this is going to be about how we can embed 6 lessons with challenging or chronic pain presentations and how we can rethink our practice to get a successful outcome. So going around in a clockwise direction, we're going to use hip and groin pain or osteitis pubis as the vehicle basically for today. But we're going to look at the clinical definition, the prevalence, etiology and causative factors, moving through clinical presentation, physical assessment and how we diagnose this particular condition, treatment management and prognosis, and then we're going to pull it all together with 6 lessons learned and some prevention strategies for chronic presentations. First though, I think we need to look at some terminology because the word osteitis pubis gained a lot of traction about 15 years ago. It was everywhere. And it is an umbrella term, but now we're seeing another umbrella term that sits over that, which is chronic or long-standing hip and groin pain. So it's a presentation that encompasses lots of different clinical presentations, and there's a reason why we have an umbrella term now, and it's because it actually is more accurate. Because what we see is we don't see one particular condition in isolation, we actually see a couple that overlap. And that makes it more complicated and harder to treat. So with the overarching hip and groin pain umbrella term, within that we can see if we look to the far right, we've got a joint pathology that might be specific just to the joint itself, so an articular issue. And that could be something like a labral tear, something that's linked to the acetabulum and the femoral head itself. Outside of that we could see like a bursitis, so something that's close to the joint but not actually in the joint. Then we look at the osteitis pubis umbrella term, which is lots of different things that it can encompass that as well. The broader is a tendinopathy or an enthesopathy. I can always say that word not quite right, but the enthesis is the part of where the tendon inserts into bone. So it can be considered the same thing as a tendinopathy. Of course, underneath that we can see the adductor group, rectus abdominis and iliopsoas can be some of the muscles that are involved in a hip and groin pain presentation. And then there could be another sub-branch under the adductors, of course, as well, because there's quite a few of those. Outside of that, the osteitis pubis term also encompasses things like bone stress. So that could be osteoedema or another stressful condition where the bone is implicated, as well as fractures as well, which are less common but still prevalent. And then we've got the other conditions like hernia and nerve entrapment, which are not as common but still can be implicated. And so this term can often encompass a few of these conditions that are intertwined. And we'll talk more about that in a second about how some other things can come into play. But it's just worth looking at terminology first and understanding what we're going to be talking about today. So what is OP exactly? Osteitis pubis. OP is its common abbreviation. But it's commonly seen within an athletic population and it's characterised by hip and groin pain that is commonly associated with activity. So that means that someone's going to get pain with activity, like running or playing a sport, or very soon after. And that can sometimes can stay with the patient for a number of days, or it could be chronic and long-standing and constant. So there's some variability in that. But often exercise is the key factor. It's an inflammatory condition that affects the pubic rami, the symphysis and or the musculotendinous junction of the adductor group or another muscle within that region. So there's lots of different structures that can be involved as well, not just the tendon. The tendon, enthesis and or bone can be involved, and it's prevalent among young athletes in sports that have a repetitive nature. So those that have kicking, twisting, changes of direction, sprinting, those sort of things. So some examples there are hockey, AFL, soccer, typically kicking sports. So AFL is kind of the main sport that we see this associated with, and that's a really big sport in Victoria, and it is over here as well, which is sort of part of the reason why this is included in the presentation. It's inherently really difficult to treat and successfully manage for health practitioners. And its prevalence is around 5 to 14% of players each season within an AFL team. So if we think about that, if we think about the suburb that we're in right now, or the suburb where your clinic is in right now, the local football team to that suburb will have at least one player right now in that team playing with this condition. Now they might be playing with the condition, playing through the pain. They might not be playing because of the condition, or they might be just about to get it. So they've got the early signs, early symptoms. So it's fairly common, and it could be within that varium as well of where they're actually, what stage they're at with the condition. It has a significant impact on the time and performance. So we're looking at a typical lifespan, or a typical span of the condition being prevalent is about usually several months. So if someone gets this, they're going to be out of action for a couple of months at least. It can sometimes last years though. It can sometimes put people out of action temporarily and almost permanently sometimes too. We've all heard of Chris Judd, hopefully, in this state, because he's a dual Brownlow and a premiership player, and he spent a lot of time in WA playing for West Coast, but he's had that condition as well, and he had just about every treatment under the sun, and it wasn't successful for a long time. Highly medicated, kept playing through the pain, which is pretty typical for this condition. Didn't impact his career too much, as we know, but and he's had a number of other conditions, but he is a huge advocate for manual therapy, and he's, like I said, he had a lot of things, just all barring surgery pretty much, to try and alleviate the symptoms of this condition. So let's look a little bit deeper into the anatomy considerations of what this presentation looks like, because that's really important. We need to know what we're treating. So the tissue and how the pain behaves is a key telltale sign of what's going to be involved here. Is it bone, is it muscle, is it tendon, is it joint? They all behave differently. We need to consider the differential diagnoses as well, which we're going to go through probably I think in the next slide, of what might be involved here, so not to be ruled out. Let's consider the attachment. So like I said, it's very common to see a number of different muscles involved, but it's great if we can isolate it. And the image on the right here, we have deep and superficial layers of the muscles around the pubic region. And what we're looking at is the site around that pubic bone, or around the hip itself, the hip and groin, is where the symptoms normally preside. And on the right-hand side, the superficial muscles like gracilis, adductor magnus, adductor longus are typical contributors to this, but the deeper ones as well, such as pectineus and adductor brevis, are also really, really common. So understanding where the attachment site is of each of those muscles, being able to palpate that and isolate where the symptoms are really key telltale signs to see what's involved with this, and that it is in fact an osteitis pubis or tendinopathy type condition. Because if you can't reproduce the pain by doing something like that, you could be looking at something else. So consider the attachment of where the symptoms are. Consider the aggravating factors as well. So is it more painful after activity? Is it more painful after a muscular contraction? Can we isolate the agonist? What muscle is causing the most pain and its action? We need to consider the global stability and conditioning and asymmetries. Typically when we see an adductor-related pathology, there's also going to be abductor issues as well. So the glute minimus and medius are often implicated here as well. We know that those two muscle groups work in a synergistic pattern to stabilise the pelvis. So if one's overactive or underactive, the other's going to be underactive or overactive as well. So there's a balance that we need to find. Clinically, when we're testing the adductors, they adduct. That's really simple. So we can ask someone to push their knee into your hand and you're testing that adductor group. But functionally, they're very, very different. So adductors aren't really adductors functionally. If we think about the typical pattern of someone running and especially kicking, when the hip is actually in extension and they've got to swing that leg through from extension into flexion, the adductors play a really critical part in that movement. It's not just the hip flexors. So that's something to consider as well, and that's why it's so prevalent in those kicking sports like soccer and AFL. Other factors such as previous history or injury play a really pivotal role in this. Quite often what we see is that someone's had a minor strain in the adductor, they haven't undergone appropriate recovery, and that's progressed into something a little bit more chronic. That's often how it starts. So we need to understand that, see the warning signs, and especially if someone has had that previous history of an OP presentation, they're more likely to get it again. So some common causes of long-standing groin pain. So this is broken into three categories. There's common, less common, and then things not to be missed. So the things not to be missed aren't really common, don't see them very often. Quite often they're picked up early, but they're things that we do need to screen for as well. So on the left-hand side, the common factors are your tendinopathy type presentations. Myofascial tightness as well, really common. That's the main thing that comes in. We can have iliopsoas related issues as well, and a bursitis as well is not to be ruled out. Abdominal wall conditions are also quite common, involving the different structures around there. Hernias as well. And then we've got pubic bone related issues such as bone stress, and then hip joint related issues like a labral tear. These are all really common. So these are the common things that are going to walk through your clinic door when there's a hip and groin related issue. The less common are things like stress fractures or bone issues to those different structures that are listed there. Nerve entrapment is also less common, and then referred pain from another area, such as a sacroiliac joint or lumbar spine. And then apophysitis is also less common. Not to be missed, and these are the important ones, the slip capital femoral epiphysis, Perthes disease, intra-abdominal anomalies. So we're talking things like UTIs, prostate issues, and gynecological issues as well. Spondyloarthropathies, avascular necrosis of the femur, and of course tumours as well. The key factor with all of those things on the right is you're not going to be able to provoke the pain. So you're not going to be able to reproduce the patient's symptoms if they are presenting with one of those conditions. So that should be a warning sign. It should be a red flag for you. If we're unable to reproduce the patient's pain, then generally a referral is probably a pretty good idea. Everything on the left-hand side of this page, you should be able to reproduce fairly easily through a clinical test, a muscular test, length and strength tests, or something similar. So I really like this slide because of the picture on the right. It shows the interrelation of different structures. So if we were to use the example of the adductors being the prime tissue that's involved, you can see that there's going to be some overlap primarily of the hip joint. If there's pain in a region, in that region, the hip is not going to have its full range of motion. There might be some other considerations or painful factors associated with the hip. There's also going to be some overlap with the pubic bone potentially as well, especially something that's got a long-standing chronic nature, then the bone may be implicated too. The iliopsoas is also going to be implicated. We know iliopsoas and adductors share the same action in a lot of way. So if there's an issue in one, there's going to be some kind of issue in the other. There's probably not going to be too much of an abdominal wall interrelation. So the same thing if there's an iliopsoas issue, there's going to be overlap with the abdominal wall, the hip and the adductors, but probably not so much the pubic bone because the iliopsoas muscle doesn't attach there, right? So that's what I mean by overlap. We're typically seeing a couple of things together with an OP type presentation. So some other epidemiology factors for someone who might be more susceptible to this injury is gender. Males are more affected than females. That could have something to do with the participation rates in sports like AFL and those kicking sports. There's a higher participation rate for males. But it might also have something to do with the anatomy of the pelvis. So females having a wider pelvis may mean that they're less susceptible to this condition. We don't really know yet. Age, young adults, again, more susceptible and could be related to the participation rates in sports as well. Previous injury, like we described before, leaves someone more susceptible to getting this as well. Biomechanical factors such as imbalances increase the risk, but by far the most common cause of this is overuse. It's poor conditioning, and it's usually when someone's doing too much too early. So they're returning to sport after a period of rest and they haven't done appropriate conditioning, or they've upped their training levels in some way where it's causing repetitive stress to a tissue. So that's the main reason why we see it. So how do we identify it? There's a number of different things we can use to identify this, and it should be relatively easy to identify clinically. So that means we should be able to identify it in the clinic room without it having to go for a scan or to see another practitioner. So there's three things that I've listed here on the slide that have a really high reliability in terms of how we can identify it. The first one is palpation, which you wouldn't have thought would be. You know, it's a pretty low in terms of how that's used clinically. But if you're able to press on the affected tissue and you get a painful response, that's a really reliable sign. However, we need to ensure that the practitioner reliability of what we're pressing on is understood. So that means knowing your anatomy, knowing what you're pressing on, knowing what structure is going to elicit that pain. So it has a moderate reliability. The adductor squeeze test, which is what I'm going to go through in a moment, has a very high reliability. It's quite good specificity as well. So that's a test specifically for the adductor group, which is quite often used nowadays as a screening tool even in elite sport. The Faber test has a moderate to high reliability, sometimes otherwise known as the Patrick's test. It's basically a length test. It doesn't have a great specificity though, because it is a length test. So if there's a labral tear or hip joint related pathology, it's going to be positive as well. So it's not really specific for an OP or a tendinopathy type presentation. Don't rule out the other tests, like your clinical testing procedures, such as your hip range of motion. So that includes active, passive, resisted, joint-specific tests to rule out things like labral tears or articular issues, and then also functional tests as well are important to understand what other factors might interrelate with this. If it gets to the point, a medical imaging is sometimes required, and an MRI is usually the scan of choice. And the two pictures on the right of this slide, one is the image I used before with just the anatomical overlay, but the one below is actually an MRI slice, frontal plane of the exact same location. So you can see the two pubic bones there. And if you look at the one on the right of this side, which is the patient's left, you can see how that's glowing. It's a little bit more prominent. That's a reaction. That's a positive sign in an MRI here of someone with an osteitis pubis condition where the bone is affected. So that is bone stress that we see there, that glowing. If you look a little closer, you can see a little cleft on the inferior medial part of that bone as well. That's another telltale sign that the tendon is involved, another hyperactivity. And then you can see this little bump just on the top of the pubic symphysis too. That bump is normal, but this is a little bit more pronounced. So that tells us that the pubic symphysis is also affected. So this is quite an advanced case of an MRI finding of someone with this. So I'd like to go through just one orthopaedic test because this is the most relevant and it plays a really key role in the case that we're going to go through later. So we're going to use all of this in a case-based approach in a moment to sort of demonstrate how I've used some reasoning to treat effectively this condition. So this is quite a simple test. It's done with the patient in a supine position with their hips flexed at about 45 degrees, knees at about 90 degrees, and basically a fist is between the knees. We ask the client to squeeze into that fist. So it's a bilateral testing test. If it elicits pain, such as especially the familiar pain that the client has been experiencing with exercise, it's considered a positive test. It's really important when doing this test that we do ask the client to gradually squeeze in there, because a forced squeeze can cause a little bit more damage to an issue if it is really severe. But it's a very, very reliable test. There's another way that we can do this as well, by having a sphygmomanometer or a blood pressure cuff between the knees as well, and just test the pressure that they're able to push into that blood pressure cuff. This is really good because it's really easy to measure, it's consistent, and it aligns with the literature as well. So a squeeze test of less than 225 millimetres of mercury is considered that the person is at risk of developing some kind of hip and groin pain related injury. Basically, we're seeing 200 to 300 millimetres of mercury for males as normal, uninjured, and 180 to 280 for females. And that's slightly variable depending on the exercise, participation, the specific sport, how strong they are, how much strength and conditioning they've done in the past, all those other factors. But basically the 225 is something that's used now in elite sport. It's one of these tests that is done prior to activity. So if you've got an athlete that has maybe some mild symptoms, some soreness, and they're getting a test of lower than 225, they might need a little bit more time in the gym before they go back on field. So it's quite a reliable test. The other variant is what we call a Copenhagen test. It's done the same, but it's just held for a bit longer. So it's a 5-second hold, and usually that can elicit the pain after a little bit more time of the muscle being activated, especially if the client is already warmed up a little bit, or if they're dead cold. Sometimes that's helpful too. But really reliable test because it can be done the same way every single time. It's easy as well because the client can do it too, which is something that I'll embed in one of the lessons. Is if your client can measure their own progress, it's much more empowering for them. So how do we treat it? What's been known to work? It's a notoriously difficult condition to treat for all practitioners, and has been for a very long period of time. The evidence that we see is really biased to an exercise therapy intervention, not necessarily manual therapy as such. It's considered a tendinopathy or an encephalopathy, as described before, so we should be treating it as such. So what does a tendinopathy or a chronic tendon condition like, and what doesn't it like? There's a little table here that we know that tendon conditions or tendinopathies, they really like isometric exercises. Isometric exercise is one where it's a hold. The muscle isn't changing shape, it's not lengthening or shortening, so it's a sustained hold is an isometric exercise. Really good for pain management. The time under tension principle is something that tendinopathies really like. So that means that there's consistent exercises where the tendon is placed under tension, and that slowly helps to rebuild its anatomical structure. And a progressive strengthening approach. Tendons don't like manual therapy in isolation, okay? Especially manual therapy directed at the tendon can sometimes make things worse. Stretching or compression doesn't do them any good, and dry needling at the site is not a great thing either. Dry needling can be used for the muscle belly itself, but into the tendon is not a good thing. The reason being is when we see a tendinopathy, the tendon actually changes, its anatomical structure changes. We see higher capillarization and a higher fluid content. If you can imagine a rubber band that's full of water, it's going to be less rubbery. It's not going to have as much tensile strength. So we don't want that to occur. So any treatment intervention that's going to encourage blood flow and a lot of fluid into that space is not going to work. The best way to strengthen a tendon is to put it under pressure, tension. And that's that sustained time under tension principle that we've seen that's pretty consistent now and does tend to work quite well. A combination of therapeutic interventions obviously will work best because a manual therapy approach is going to allow the client to do it comfortably, going to do the exercise intervention comfortably. They're also going to be more inclined or more encouraged to do it as well. Pain is another factor. Is pain a problem? Really early with a lot of these chronic pain conditions, it was said that pain is bad. Stay away from pain. The exercise that you do or anything that you do shouldn't cause pain. Now we're seeing that there's a little bit more flexibility within that. Pain is not necessarily a bad thing. It doesn't mean you're doing the wrong thing, but it's all about tolerance. That's the key word. So if someone can complete some form of activity with a little bit of discomfort it's not necessarily a bad thing. If they're going, and usually it's around about a 3 to 4 out of 10 pain mark. If you're going outside of that, then it's too much. It needs to be scaled back. But if you're operating within that tolerance range, it's usually okay. So, without further ado, let's meet Matthew. There he is. Good of him to take a professional shot for me for this. That's not actually him, by the way. And his name's not Matthew either. I've changed his name to protect him, but this is a real client that I saw not that long ago. So he's 32 years old, he's a carpenter, so he's a tradesman, he's got 2 kids and 1 on the way. He plays local football and has done since juniors. So what that means is that he's trained for every season, every football season. He's trained 2 times a week and played on the weekend every year since he was in probably primary school. So we're talking about 15 to 20 years. The 2023 season, he played with Osteitis Pubis and he was medicated for pretty much the entire season. So he played through the pain. He continued to play, but now it's consistent this year. It's persistent, sorry. He's unable to play, hasn't played. Can't sprint, can't change direction, can't kick. It's aggravating when he steps over things. So because he's a carpenter, he works on site. He's got to climb ladders. He's got to step over things. That's been causing a little bit of aggravation. That's his livelihood. He owns his own business too. So the previous treatment before he saw me is that he had been seeing an osteopath and I should say that it was diagnosed by a sports doctor as well 12 months ago prior to seeing me. But no MRI. So no real specificity in terms of that diagnosis, but diagnosed with OP. So he's had 6 months of osteo treatment and Pilates 2 times a week. He said it's helping, but it's not really progressing, and that's why he's coming to see me. It might be that he's not playing. It might be that he's scaled back from all that aggravating activity, and that's why he's stagnating, but he wanted to take that next step. It's been going for too long for him. So when we had a look at him, all of his movement was all right. He had pretty good range of motion. He had some stiffness in the lumbar spine and hips, but nothing too bad. The adductor squeeze test was positive, but there wasn't really any other significant finding. So I did all the labral tests, all the pelvic tests that we would see for joint structure. No referred pain, no straight leg raise, slump tests or anything like that negative. So there's no other significant finding that had any other sinister pathology behind it. So I did all of that screening. I was fairly confident that we're looking at some kind of osteitis pubis type presentation, but like I said, that's an umbrella term. So, lesson number 1. Question, don't assume. I could have very easily run with that diagnosis that someone else had given him, as being OP. And that's an umbrella term too, remember. When I asked Matthew, what is osteitis pubis? I don't know, something to do with my pubic bone? Don't really know, it's painful though. He didn't really know what he was looking at. That hadn't been explained to him over that course of time. More qualified practitioners aren't always right. So he was diagnosed by a sports doc, but there was no MRI, and he was given the diagnosis of osteitis pubis. But that's quite broad. Treat every patient as a new case. Let's take a full history, do your full evaluation, and you make the decision. Right? Trust your professional judgment. And it can be helpful in some cases to use someone else's diagnosis, but you need to make your own judgment. Going with the flow can be dangerous. I could have just said to Matthew, great, keep doing your Pilates, keep seeing your osteo, no worries. I'll just do some manual therapy, some manual release, and we'll leave it there. I'm sure we wouldn't have got anywhere if I had done that. We need to understand our role within that multidisciplinary team. I'm still now working as a team, and I'm really conscious that when I talk to Matthew, and when I put my treatment intervention and my explanation on things, it's not discrediting anyone else, right? They weren't wrong. They're doing their treatment approach. I'm going to do my treatment approach as well. And that's going to work together. So what did we do with him? Did some manual therapy release. Not rocket science. It wasn't anything that, that was innovative really. It was some deep tissue massage, some myofascial release to the adductor group. We did some positional release technique to the iliopsoas on both sides, TFL, and some glutes. A little bit of dry needling to the glutes as well. There was some trigger points in there too. So a pretty standard sort of treatment. But what I did implement was a really simple strengthening program. What was apparent to me is that in particular, his adductor brevis muscle on the attachment site was really weak and painful when it was tested. And I identified that through palpation and through the adductor squeeze test primarily. So I wanted something to target that muscle. He's doing everything else, right? He's getting his strengthening from his Pilates. He's doing that global approach. There was nothing that was really targeted though. So that was where I needed to step in. So there was two things I gave him. The first was a single leg bridge, which is the image at the top there. So that was to address his range of motion deficit. He had a small deficit in hip extension. Wasn't really that bad, but nonetheless, a hip range of motion issue should be addressed. That's usually an easy place to start. So a single leg bridge is done simply just lying on your back with your knees at 90 degrees, lifting your bum up as high as possible. What we should see is a straight line from the knee down to the shoulder. I gave that to him, 15 to 20 reps, just one set, but do it 4 times a week. I tried to make it easy, so I gave him the same reps and sets for a bent knee fallout, which is the image down below. So a bent knee fallout is basically, again, lying supine with the knees at 90 degrees, hips at about 45, with a band around the knee that's attached or anchored laterally. So doing a deduction, so with his knee being brought into the midline against the resistance, and then going back out again with the resistance. So that targets the adductor brevis muscle very specifically. Now, the advice that I gave him is I wanted him to feel fatigue. So when he did the single leg bridge, I wanted him to feel some fatigue through his glutes and his hamstrings. When he did the bent knee fallout, I wanted him to feel some fatigue through that adductor group. Okay, a little bit of discomfort is normal. Don't be afraid of that. I wanted him to complete it every other day. So I didn't want to overload. He was already doing his Pilates and doing some water running and a few other things. So on the days that he wasn't doing any of that, I wanted him to do what I'd given him. And to see him again in 6 weeks. Didn't think I'd really be able to see too much of a difference if it was any sooner than that. So lesson number 2, let's simplify the complex. So Matthew was given an Osteitis Pubis diagnosis, but he didn't know what that was. Now, I've just been speaking to you for about half an hour now on what Osteitis Pubis is. I'm talking to a client who doesn't have any anatomy physiology. He's not a health practitioner. I needed to simplify that for him really quickly within that treatment room. He needs to understand what is going on in his body. The way I did that was he had a weak adductor, and that was prone to injury. So we needed to strengthen it. If we strengthen it, he's going to feel better. Really, really simple approach. A complicated presentation often needs to be treated with a simple approach as well. So I found a weakness, I found a range of motion problem, just going to address that. How can this be communicated to the client to ensure they are informed as well? So we just heard about informed practice, informed consent. It's just as important for our clients to understand what condition they have and what role they play in that as well. I needed to challenge his beliefs so that they aligned with the treatment plan. You can only do that if you ask questions. I needed to understand where his thinking was at to ensure that he was aligned with the treatment trajectory and the treatment approach. Needed to develop a bit of a mantra, explain the why. If I do X, I'm going to get Y. If I do these exercises, I'm going to get stronger, which means I'm going to have less pain. And again, check understanding by asking questions. So the second treatment, he came in about 8 weeks later. We saw a little bit of change, but it wasn't that much. It wasn't anywhere near what I thought I would be able to see. He felt great after the manual therapy. He did the exercises and they were causing a little bit of discomfort and he was wary of that, and that might have been a reason why he wasn't as compliant. Basically, he wasn't doing what I wanted him to do. He wasn't doing them 4 times a week. He was doing them once at best. So I had to really reinforce that compliance with him. I don't think I did a good enough job with that. He was also stacking. He was doing too much. He was doing water running, he was doing Pilates, he's working, he's got a physical occupation, he has limited time, he's got a young family. All of this stuff was just too much for him. He was convinced that the manual therapy works, but he wasn't really seeing the holistic picture. So we had some challenges with compliance. So that brings us to lesson number 3. We need to prioritise. So this is a strategy for compliance. He was too busy. He was doing everything else. Sometimes less is best, and we need to know what's going to give us the best return on investment. I had to involve him in the decision making for that, and I said, you've tried 6 months of this global approach, of this Pilates global strengthening hip stability type approach. Let's try something targeted. We haven't tried that yet, so we need to commit to that. So if you do anything, do that. So I gave him permission to let go of some other stuff. Let go of the Pilates, let go of the water running, let go of a little bit of the running stuff, and actually focus on what's going to target where his pain is. How can we incorporate that management strategy into daily life as easily as possible? He was really busy. I'm sure we've got a lot of parents in the room that understand that you have really limited time to commit to yourself at the best of times, let alone spending, trying to find 5 to 10 minutes at the end of a really hard day to try and do some exercises. But that was the best time for him. So I asked him when would be the easiest time for this to be incorporated. And he identified that when he got home, he had a shower, straight after that was the best time to do it. Okay, that's when you're going to do it. Take micro steps if necessary. They will build confidence and a pattern of behaviour or a habit. That's what we really needed to instill in this case. So a couple of weeks later, I saw him again. Drastic, huge improvement. So the symptoms were almost completely resolved in another couple of weeks. The strength continued to improve. This was now 11 weeks since I saw him the first time. He was more consistent, so that last approach of prioritising really worked for him, and he was doing them religiously 4 times a week. Felt great after doing it too, so that was great. That was really good confirmation for him that he felt a little bit of discomfort doing them, but while he was after doing them, he felt really free and much more mobile. He was keen to return for the manual therapy release and the symptom relief, which I was happy to provide for him, but it wasn't kind of the core focus of the intervention. He'd returned to running, and he said, I saw him on a Thursday or a Friday before the weekend, and he said he wanted to try being the runner for the footy team on the weekend, and for that's running messages. I said to him, that's okay, you're running in a straight line now with no pain, so that should be okay. However, he needs to be aware that when you're running messages, you're going to be changing direction, you might have to sprint to get out of the way when the umpire's within your zone, things like that as well. He was aware of that, understood the risk of doing that. So he went away on the weekend. Turns out the seconds team was short. He played. He got through the match. He had significant post-match soreness, but not in the left. The left was where the problem was, no symptoms. The right side was where he had the issues, and it was in his hip flexor. That could be because he's right-footed, he's not used to the kicking, he's not used to the activity, and there's a bit of DOMS, a bit of delayed onset muscle soreness in there. But it's quite fascinating, right? You would have expected his left side would have been the issue, right side was. So he returned a short time after that for some more manual therapy. So lesson number 4, we need to measure our progress. And I mean actually measure it. So for Matthew, the adductor squeeze test was really simple. He could just put a tennis ball or something between his knees and squeeze into that, and he'd know whether the treatment was being effective or not, based on the amount of pain and the amount of perceived strength that he was able to input into that object. How do we know the treatment's actually working? How do they know the treatment's actually working? That can be hugely empowering for a client to actually see evidence of your work working. So what sort of confidence are we building there? Empowering the patient as well. So what do I do if X happens? So the question that I raised with Matthew is, what are you going to do if you do that squeeze test at home and it is painful or it's more painful? What are you going to do next? And he was able to give me that information. So I gave him a lot of strategies on how he can manage the pain, on what he might need to do to scale back to ensure that the treatment trajectory is still consistent, because it's a bumpy road, right? We're always going to see bumps in the road. But I gave him that skills and knowledge to be able to empower himself. And that level of agency can be extremely powerful, not just for the treatment trajectory, but also prevention later on down the track. So let's look at a bit of a prognosis timeline that we had with Matthew. So the first treatment he came in, we just did a manual release, simple strengthening program, but we had some challenges with compliance. The second treatment was about 8 weeks afterwards. We had some improvement and we reinforced the priority exercises. So we really had to reinforce what was going to give him the best return on investment for his time and what he needed to focus on. The third treatment, we had significant improvement. And it was really just about focused on the release, just the tension, just the built-up tension that we saw globally. Treatment number 4 was post-match. The left had no symptoms at all. The right side, we had some tenderness, possibly due to the activity. So 2 weeks following the 4th treatment, he continues to play. So to this day, the season's over, but he continued to play after that, and he was able to self-manage. So the total time that we saw was about 12 weeks, but it could have been shorter if we really had to prioritise what he needed to do after that first session. So we wasted a bit of time in between the first and second. He continues to improve and he's able to self-manage to this day. So that's a pretty short time frame with this particular condition as well. But I think the main factor is really how we empowered Matthew. So lesson number 5 is be consistent. Consistency is key, but not for everything, okay? Don't bang your head against the wall. It's really important that we follow a principles and evidence-based approach, and that's where the consistency comes from. He could have kept doing the same thing. He could have kept doing the Pilates and just kept doing that, and I'm sure that there would have been another 6 months where he would have had this condition and it would have been the same. Don't get stuck doing the same thing over and over. Don't follow someone else's treatment plan. What if you miss something? What if there's more to play? Find what works and stick to it, and that's where the consistency needs to be. Also, assessment and measurement reliability. Let's be consistent with how we're measuring the progress of a treatment. We need to be able to do that, and that's got to be consistent. So, for example, you do the same thing the same way with the same environment, the same considerations. That gives you an accurate measurement. And chronic conditions often need to be reverse engineered. So if we see a chronic condition that's had a repetitive nature, it's had consistency getting to where it is, it's going to take consistency to get it back out. It's not going to happen overnight. Chronic conditions usually take a long time, a matter of months, to treat, and using a consistent and evidence-based approach. So prevention and long-term strategies. As we're sort of coming to a close, we're talking about some global things that we can incorporate within treatment, and we're normally talking the back end. So when we've got someone to a stage where they're returning to activity, their symptoms have somewhat resolved, now we're focusing on prevention. Those same prevention strategies that we implement at that time can also be applied all the way back at the start when someone is just starting to have those symptoms. They're often the same. So if we started to incorporate a lot of the prevention strategies at the beginning of when Matthew started to feel those, the pain in the area, especially post-activity, we probably would have been able to resolve it quickly. So prevention, like we all say, is better than a cure, but often the prevention approach can be used at either end of a clinical presentation. So training principles and conditioning is the number one thing with a lot of athletic chronic pain presentations. Often they're doing too much too early, not enough conditioning. Adjusting the training loads as appropriate pre-season conditioning can help prevent overuse, of course. Strengthening programs are really important. Often they're not applied, especially at a grassroots level or at an amateur level, obviously are at an elite level. So we need to be mindful of that and how much time clients actually have and about prioritising what they could do to ensure that, that a preventative approach is followed. Early diagnosis is important, of course. If we catch things early, then they don't progress to a chronic condition. And as I said earlier, the adductor squeeze test is now a common testing protocol in elite sport to screen for osteitis pubis. We saw, I don't think I mentioned at the start, but we saw 15 years ago as osteitis pubis being hugely relevant. It was kind of in the public eye. We're not seeing as much of it anymore. We're getting much better at finding the symptoms before they start to become chronic. So it's still out there, but it's just not as much of it as what there was about 10 to 15 years ago. Lesson number 6 and the last one, life is not a textbook. Every case is different. There's no cookie cutter approach to the way we did this. If I didn't ask the questions about Matthew's family life, home life, occupation, and those sort of things, we could have taken a very different approach. I had to really simplify for him because he had a lot of other things going on. There might be other clients that you can go a bit more complicated and you can load up a bit more with different things that they can do. So you've really got to pick your battles. You've really got to understand the unique circumstances that your client has and the position that they're in. Listening is of paramount importance. Asking questions and actually taking the time to listen and letting them tell their story and respond accordingly. What other subjective considerations are at play? So their personal circumstances, their beliefs, their attitudes and opinions. And what do they think of you as well? That's an important part as well. That role, that rapport building that happens really early on, and our part to play in that. So everyone is different. So to summarise the 6 lessons that we've gone through from top to bottom. Number 1, question, don't assume. Assumptions can be dangerous and you need to make your own judgments and trust them. Simplify the complex to ensure the patient is informed and can follow the treatment trajectory as well, and they're involved in the decision making. Prioritise. What's going to give you the best return on investment, and what should the patient really focus on? Measure progress, validation for both the patient and the practitioner, and this can be a major confidence building exercise. Consistency is key, using a principles-based approach, and life is not a textbook. So a patient-centred approach around their unique circumstances needs to be considered with treatment planning. That is it for me.